All right, everybody, you're here for a session on recurrences, co-hosted by the American Head and Neck Society and ThyCa. We have a wonderful esteemed panel, including Dr. Ho and all of our other doctors who can go around the room and introduce themselves quickly again. And then Jennifer Holcomb is also with us from Save Your Thyroid. What are the odds that I'll have a recurrence?
Go ahead, Anupam.
Sure. Yeah, so this question depends on what the initial thyroid cancer risk of recurrence was based on the surgical pathology for the most part. So we look at the staging as well as the ATA given risk of recurrence. And then it also depends on how the response has been, like how the survivors responded to the treatment, surgery, radioactive iodine. So based on the tumor markers and the imaging following those treatments, so we say you had an excellent response or an indeterminate response, or there is still concern there. So if they've had an excellent response from a low-risk thyroid cancer, the risk of recurrence is low, less than 2 to 5%. And that risk keeps falling the longer we monitor. So if you're 10 years out from a low risk, that risk is very minimal, less than 1 to 2%. For a high-risk thyroid cancer, usually patient would have received a surgery and radioactive iodine, and the high risk means the risk of recurrence was about 30% or so. So 1 in 3 before those radioiodine. And that will, radioiodine plus the surgery will cut that risk kind of by half. That's a rough estimate. So the high risk with the excellent response to treatments will have, say, around 10 to 12% risk of recurrence long term. And then there's this whole intermediate or kind of this gray zone, which is in between. But most of the risk of recurrence, if there's been excellent response, no evidence of disease, is lower than 10 or 12% to as low as 1 to 2, depending on that initial risk and how the response was. And then also how long the survivors has been out from the initial treatment. Most of the recurrence risk is in that first 3 to 5 years. And the initial response in that 1 year guides us as to what that risk will be. So, and I always struggle with this. My patients ask me whether I'm you're free of cancer if you had no evidence, you have excellent response. But can we say they will never have cancer recurrence? At this point, I personally cannot say that. So that 1 or 2% also means some patient with a low risk may have it recur. But as we keep going farther and farther, that risk goes down.
Excellent. Maybe I'll ask Avi a quick corollary question. In terms of recurrences, not necessarily the odds, which Anupam has answered quite successfully. How far out from initial surgery and treatment do you typically see your recurrences in your institution? Like, is it 1 month later, a year later, a decade later? What do you think?
I think it's a great question. And it also depends on the initial stage and what we call like risk grouping of patients. Who underwent surgery, and some of them also received radioactive iodine, depending on the risk of recurrence. And I think in my practice, most of the patients, with low risk cancer, I don't see any recurrences. Maybe very few. But we always, see these patients with, disease that had spread, into the lymph nodes, whether it's like central compartment or, the lateral neck, the sides of the neck, for the patients. And these patients, that if they have like a very high burden disease, they will probably recur, in the first year or two. But I always tell these patients that, even if we see a recurrence, it's something that is usually treatable. So you can reassure them that If we monitor them, we have them come to the office, every couple of months initially. We get a good ultrasound, and I do my own ultrasound. I'm sure a lot of the thyroid surgeons also practice that, and then if we find something, we can take care of it. So it's not something that, in most cases, would risk their lives or something. So I would say the first couple of years. Rarely you see recurrences 4 or 5 years, after initial treatment.
It's great that you mentioned an ultrasound. That brings us to a question 2, right, Daria? Well, I think we can move on from there unless you had something else to add.
No, there's some great questions in here. So one person is talking about, having gone through the surgery and everything and has had several recurrences and multiple surgeries. And now they're discussing another round of radioactive iodine. And it looks like maybe the papillary is aggressive. So, she or he is wondering if they'd be a good candidate for another round of radiation, since it has recurred already after radioactive iodine. And the question is, what about like watching and waiting and using like more frequent ultrasounds for surveillance?
This is an excellent question. Anupam, I'm going to point back to you because of that first part of the question, giving multiple rounds of REI. I know sometimes there's some fierce debate about whether that's useful or not as useful. Go ahead.
Yeah, so that looks like these questions are 3 or 4th rounds, I guess. That would raise the concern that maybe the disease is not responding to radioactive iodine or RAI. So instead of just kind of doing this empiric treatment, which used to be the standard a few years ago, we now kind of don't do that unless there is clear uptake of radioiodine. But if the disease has progressed despite therapeutic doses, like you got a treatment dose, adjuvant dose, and this is the 3rd or 4th time, we would probably want to make sure like where else the disease is. You probably get a PET scan at this time to better characterize the disease. I would do genetic testing, looking at where those recurrences are. I don't know if the question clearly mentioned the focus. The surgical treatment for a recurrence, if it's possible in that area, local radiation for a recurrence, and then thinking of systemic treatment at this time. There is also now some advancement in this question of redifferentiation, right? So there was some radioiodine uptake, some response, but not optimal. And can we give some systemic treatment for a short amount and then treat these patients with radioiodine? Those decisions need to be based on genetic testing. So I would really focus on getting the recurrent tissue, analyzing that for genetic testing, doing a PET scan, rather than just going for empiric 4th dose unless there is clear uptake of radioiodine on a scan. We initially treat it, right, 1st or 2nd time and look for a post-therapy uptake. But the 3rd or 4th time, I wowould not do that empirically based on this information that is there.
I'd like to echo what he just said. I think, in the past, we used to give multiple RI treatments, radioactive iodine treatments, and these days we tend to shy away from it because as we said, after the 2nd time, the 2nd dose, if the tumor is not responding, if there is another recurrence, we assume that this is a resistant disease. And also, I like to remind everyone, and I always tell my patients that radioactive iodine has a price, and we all have patients with salivary gland issues that sometimes need even interventions. So this is something that I would consider in my back drawer. But then if we can do another surgery or even follow these patients with serial ultrasound, because these recurrences in most cases tend to grow very slowly, then that would be my approach.
Right. So just as a reminder, we don't know the particular circumstances of particular patients. In general, though, it sounds like the consensus is you're not wrong to do multiple rounds of RAI, but the field seems to be moving a little bit more away from it in modern times in 2024 because of other options and perhaps better understanding of the biology of the disease. I think that's probably the best way to put it. So, and we'll be covering other ways, that you say John and others have pioneered to treat recurrences that don't necessarily require RAI, and we'll get to them later on in this discussion. So Daria, should we move on to the next official question or anything else in the chat?
I think we should move on at this point to the next question and see where that takes us. So the next question is, what are the best ways to conduct surveillance to look for possible recurrence? We touched on it a little bit, but are there other things that could be done for surveillance?
Sure. Maybe John, we'll have you take a shot at this. There are many different tools, some better than others. What is it like in your practice?
So there's a couple of things that just form the backbone, and that's first the thyroglobulin and the TSH, T3, T4 thyroglobulin antibodies, just the lab panel, and what's the story that those are telling you. And then the second backbone that goes with that is the ultrasound, which is what we primarily use to look for structural disease in the neck. And when there's dysynchrony, when the two stories aren't the same, perhaps you see structural disease and your labs are stable, or when your labs are abnormal but you don't see disease, that's when you escalate to the next sort of imaging modality. A PET scan was mentioned, and almost all patients immediately want a PET scan when they find out that they've got cancer. But a PET scan is actually one of the last things that we go to with thyroid cancer, just because of the fact that most thyroid cancers don't actually light up very well on a PET scan. And it's only the more advanced or the multiply recurrent cancers that come back or that show up super well on a PET scan. I think another point is there's some good work that has come. University of Michigan published a while back that looking too aggressively for a recurrence on a low grade, small thyroid cancer, you're actually more likely to have surgery, but you're less likely to have any benefit as far as your overall quality or quality of life or even your longevity. And so we really have to balance that with a lot of these cancers. We don't want to be doing too much surveillance, which is a little bit counterintuitive to a lot of patients.
John, what about some of the other imaging modalities you hear about, MRI, CT? How do they compare to straight up ultrasound? Mm-hmm.
So they each have different advantages at different times. So if you ultrasound is the first thing you go to if you suspect that there's a recurrence based on your lab work. And so if you can't find something on ultrasound, then your next step is you'll go to a CAT scan. And that CAT scan can start in your neck. You can include the lungs based on how suspicious you are about different areas. And that's probably going to pick up more than 95% of all recurrences between those two modalities. The real question comes is, what happens if you don't see something on a CAT scan, but your thyroglobulin is still elevated, and so you suspect that you have a recurrence? And then you start to say, well, should we do an MRI? MRIs are great for me if you've got a really advanced cancer and you're trying to see if it's invading into structures such as your esophagus, or will you be able to resect the tumor? Otherwise, MRIs don't really play a huge role unless the patient maybe has a weird contrast allergy or something abnormal like that. But most of the time you won't go to an MRI almost at all with thyroid cancer. And then finally, the PET scan, again, if you've done everything that you can do and you just don't know where this disease is, or you know that you have an advanced cancer and you want to see where it has spread, that's when you would get a PET scan. But PET scans for most patients with thyroid cancer are going to be years down the line rather than one of the things that we do right up front.
I completely agree. Basically, what John is saying is that it's a paradox. Even though the PET scan, the CT, MRI, it seems fancier, the ultrasound is actually much more fine cut, high resolution, and much more helpful for thyroid disease in particular. Yeah, Daria, anything else you wanted to add before?
Yeah, from the chat, kind of circling back to the genetic testing. One question is, which genetic testing do you recommend? And another is, are there specific mutational drivers in recurrence and response to RAI, like BRAF, et cetera?
Avi, I think you might have some experience with this. It's a little bit more of a esoteric question, at least where we are at this stage in the talk. But what is your take on this question?
Yeah, I think I mean we need to keep in mind that getting genetic testing and looking for specific targetable mutations is really something that we don't do very often. It's kind of like something for as a really remote plan that we save for patients who have exhausted all other treatments. And fortunately, we don't see it, a lot. But it's great that we do have these tools now in our armamentarium that in case we have patients who have structural disease or even like metastatic disease and are not candidate for surgery or additional radioactive iodine, that we can exploit this what we call precision medicine or precision oncology, and send samples from the tumors, whether this is the primary tumor or the recurrent tumor, to what we call genetic testing, where we do the sequencing. Basically, we map the DNA and the different genes and look for specific mutations that we know are driving the cancer or thyroid cancer specifically in some cases. And today we have also specific drugs that can target these mutations and help us achieve sometimes great response in patients with even disease that is had spread all over, and they can respond. They sometimes there is a regression of the disease. Sometimes we get stable disease, and I think this is something that is still work in progress, and in the future we'll have more tools even for earlier disease, that patients who are even candidates for surgery, but this surgery is very aggressive or might cause a lot of morbidity. So yeah, there's a lot of things that are in the pipeline and a lot to look for.
Very well put, Avi. I think in many ways, thyroid cancer is a poster child for precision medicine. There are a lot of targets that now have actionable medications. On the other hand, those medications have consequences, side effects, toxicities that are not really worth the price unless it's, as you say, one of the more advanced cancers where conventional treatments won't fit the bill. All right, Daria. So I think that answers that mutation question. Should we move on to Q3?
I think so. Just a reminder, everybody, please put your questions into the box. And if you want to share anything about your own recurrence story without asking a question, you can also put that into the Q&A box. So, third question, if the recurrence requires additional surgery, what is reoperation like and what are the risks?
Okay, perfect. Why don't we ask Josh to weigh in from Oregon? He's in many ways subspecialized in more difficult recurrence surgery. Surgery for recurrence is going to be very difficult with scarring, fibrosis. Another surgeon's been in there, and some very tricky critical structures. So Josh, can you tell us a little bit more about how you approach recurrences? I think you're muted still.
Yeah, I'm happy to talk about it. When the thyroid has already been removed, it generally means that if there's a recurrence, the thyroid is already out at least on one side, if not on both sides. It most commonly, in my experience, when I'm involved, seems to reoccur close to where it was before. It may recur in paratracheal lymph nodes immediately adjacent to the thyroid, and be along the recurrent laryngeal nerves. I think the recurrent laryngeal nerves become a big issue. They're much harder to dissect for our thyroid surgeons, even with the monitoring and all the things that they do. Quite honestly, I'm stunned with the relative infrequency that the nerves are injured if they go into the surgery with working nerves. It's amazing to me how often they come out with working nerves, depending on the size of the tumor and the extent of the tumor. But when there's not there, a lot of the other tissue that it can get into, for example, the trachea, the esophagus, and the associated the tissues around there can make it more problematic. And so we will do things if we see that the nerve is close to being involved or looks like it's involved or may have to be sacrificed because the tumor is encasing it, even if it's working ahead of time. I often see those patients before the surgery, and the surgeon and I will go in together. The surgeon our thyroid surgeon, Dr. Shindo, will usually go ahead and remove the tumor. And if she had to resect the nerve, I'll often be prepared to do a reinnervation of the nerve and tie in the ansa cervicalis nerve directly into the stump of the recurrent laryngeal nerve. It's very nice. It doesn't, it improves the vocal qualities in a number of different ways. We sometimes still have to do additional surgery on the vocal fold, but I find that I have to do that much less frequently. A lot of the patients do very well. I would say about half of the patients that we do that on don't need additional surgery for their voice, and that's great.
Josh, let me walk you back just a second for our patients who may not be as familiar with the ansa cervicalis and vocal fold. I think what you're describing is sometimes, despite surgeon heroics, the nerve has to go because it's involved with tumor. The recurrence is just too much, and it's not worth it to leave it behind. Can you take us through what you mean when you say you were sewing something to the stump? I have a feeling what you're saying is you're working to make the voice better. Mm-hmm.
Yeah. So for anyone in the audience, I don't know if anybody has had a paralyzed vocal fold associated with treatment of their thyroid cancer, but it does happen. The tumor can take it, the surgery can take it. I've even seen radiation, external beam radiation years later take it with no persistent disease evident. And the voice is usually the most troubled. Patients will have a breathy, whispery voice that's difficult to project. It's effortful to use, and they'll often notice shortness of breath when they're talking for long periods of time or trying to talk over noise. We can do things to improve the vocal quality by pushing a sense. I don't really have a great picture, but if one nerve is not working, then your vocal folds, which are kind of come together like a V, will leave a kind of, they usually come together completely, but they can come together with a gap left. And when they leave that gap, if I push the vocal fold over to the midline with a small implant or an injectable, then the voice can be restored, and because the other vocal fold can meet it very easily. And when we do that, we can also tie a nerve in at the time of surgery. I don't like going fishing for these things after. So if the patient has had a surgery years ago and they have a nerve that's out, I don't like tying in a nerve, going in and re-innervating or trying to find the little portion of the nerve that remains. But if it's done at the time of the surgical resection and the nerve resection, then we can easily tie in another nerve in the neck that goes to some of the muscles in the neck and is not critical for swallowing or voicing or moving our neck around. And when that happens, it bulks that muscle up, and we can actually get much better voice without having to do any further surgery.
I think that's amazing. It's remarkable. And I think what you're basically saying is you're taking a nerve that has some electricity and rewiring it so that electricity makes it to the voice, the vocal cords, and so that their voice is improved rather than letting that voice nerve just wither away.
Correct. And we don't think about we think of vocal cords as like they look like these little white structures in our throat. If anybody's seen them, we think of them as ropes. They're not. They're actually muscles wrapped in a ligament. And when the nerve is cut that goes to them, the muscle underneath that ligament atrophies and it shrinks. And when it shrinks, it really literally decreases in volume and size dramatically compared to the other vocal fold. And when you tie that nerve in, it keeps that muscle. It may never move again, but it keeps that muscle really plump and looking very much like the other vocal fold. A lot of times that's enough for voice, but if it's not, even if I push it over with an implant, they sound much better. They sound really, really good.
And then in the last maybe 30 seconds before we move on to the next question, can you tell us a little bit about the aftermath, Josh, whether or not they had a nerve cut or re-anastomosed or fixed? What is your process, your strategy for voice rehabilitation?
So great question. The voice rehabilitation, issues are common after thyroid surgery, especially reoperative thyroid surgery. And a lot of times the nerves aren't cut, and the patients and they actually do work. But because of, I think it's a lot of different things. It has to do with guarding of the neck and tightening up of throat muscles around the or neck muscles around the larynx. And patients will often benefit from a little bit of voice therapy to help them open their voices back up. This is really common in professional vocalists. I think a lot of them are terrified that their nerves have been injured in some way. And I think that in the vast majority of the situations, their vocal folds work quite nicely, quite well, and they just need a little bit of voice therapy to help give them confidence in their voice. If the nerve has been cut, then we can often, or has been injured in any way, whether by tumor or by a surgeon, we can inject the vocal fold to help essentially bring that vocal fold over to meet the other one. And we can do that in the office typically. We will use injectable materials similar to those things used by plastic surgeons to fill out wrinkles and things like that in the face. We can use the same thing in the vocal voice box. They tend to last about 3 months or so. We had some materials that I thought lasted longer but aren't available anymore. And then if there's a permanent outage, if the nerve is permanently out, we usually, or we know for a fact that it's out. If I know that it was cut and not repaired or anything like that, I'll put an implant in at about 6 months. And we can push that vocal fold over at about 6 months. And if we're not sure, we think the nerve is intact, I'll often ask the surgeon or look at their operative note. And if they think the nerve is intact, I've seen a number of them come back very late, usually about 10 months out. So we usually wait a year before we do anything permanently to correct the voice.
Excellent. Good to know about that time course. Daria, anything in the chat, or should we move on to Q4?
We do have a question that's wanting to understand a little bit about life expectancy with regards to recurrences. Any thoughts on how having a recurrence can impact? I know it's tough because it's so specific to each individual, but maybe like statistically overall, people with recurrences versus those without, does it change the overall statistically, does it change the odds?
Maybe Anupam, I'll ask you, I'll just give you a scenario. You know, common things being common, if it's a classic papillary thyroid carcinoma, what are the life expectancy expectations for that you tell them? Classic
Yeah,
papillary.
I mean, 5 years survival is upwards of 99%, 10 years upwards of 95%. So even, I guess, if the question is if there is a recurrence, especially if it's a neck recurrence, it really doesn't affect the mortality risk. It's more of kind of, spread into the nerve and trachea and esophagus and things like that. Even with lung mets, the life expectancy is only is affected to a certain extent, but it's still upwards of 80%. So usually common differentiated thyroid cancer, very low mortality rate. With neck recurrences, not affected much if it's addressed in a timely manner, right? And doesn't always mean surgery, maybe mean monitored if it's a small recurrence or some kind of non-surgical treatment. Really, the mortality risk is an issue if there is diffuse metastatic, distant metastatic, in addition to neck, definitely in lungs or more. Bone metastases increase that a little bit. And if it keeps spreading despite treatment, or if it's become, say, de-differentiated or something like that. But otherwise, differentiated, even with neck recurrences, low mortality risk for the most part.
Well said. Let's not minimize, say, maybe some of the participants in the chat who maybe have outlier type cases that you've just described, but generalizable, we would say that those mortality risk is quite low overall. Okay, Daria, anything else to add?
I think we should move on to the next question. So we kind of have covered this, but I think it maybe should be revisited just to kind of emphasize how things have evolved over time with radioactive iodine. Is it possible to treat a recurrence with radioactive iodine?
Anupam, we'll come back to you again. I think you've already mentioned this, but just how often do you treat more with RAI more than once?
If it was treated with a good adjuvant or treatment dose and has recurred or did not have any uptake in that area, and now we see structural disease, then its likelihood to respond just to radioiodine is low. So I would really focus on ability to do surgery, monitor, use some non-surgical technique, rather than hit with another empiric dose of radioiodine. Would probably save that for later when the patient may need it. So we think of this cumulative lifetime requirement of radioiodine, because not without even the mild side effect, but there is some concern of bone marrow issues and myelodysplastic issues. So yes, it is possible to treat a recurrence with radioiodine, but if they received a good dose, it probably will be unnecessary and may not work. Again, depending on what kind of recurrence we're talking about.
Anupam, I know there's never a black and white answer, but I know that a magic number of cumulative RAI dose before things start to get dangerous, somewhere is in the realm of 600 millicuries. Is that about right? What is your take?
Yeah, 500 to 600 is where, most of that kind of long-term bone marrow suppression and the studies that looked at leukemia risk and all. But and that's where we start saying that really this is something not responding. So even if there was uptake, but the person's received cumulative of 500 to 600, really more radioiodine than that is not going to help. So that's, yeah.
Are there
Right.
certain mutations that would lead to the patient being non-avid and therefore maybe you wouldn't give them RAI?
Well, so BRAF mutation can decrease this uptake of radioiodine, right? It'll decrease the expression of factors that increase that uptake. But BRAF mutation is present in more than half of people with differentiated thyroid cancer. So as of now, we don't not treat with radioiodine based on the mutation. Rather, if they are having distant metastatic disease, and it's recurring and it's not being able to be addressed by surgery, and we're thinking of repeat radioiodine the third or fourth time, doing genetic testing on the recurrent or maybe the original, and if there is a BRAF mutation, then we could put in radioiodine with some kind of systemic treatment. But to answer your question, a genetic testing doesn't preclude radioiodine if we feel it will be beneficial.
So
Awesome.
there's another question in here that says they wonder what the most amount of recurrences the doctors know of. And I'm assuming that means like a person that's had it again and again and again. Can any of you speak to maybe some of those outliers that you've seen in your practice?
We'll ask Avi. For me, perhaps I've seen maybe 6 or 7 in a particular patient. That's kind of my record. Mhm. Anything?
Yeah,
anything, Avi?
I think for me, kind of same ballpark, like multiple recurrences. But I mean, the encouraging thing is that in most cases we can offer treatment. I mean, even multiple surgeries that are limited, and we're really making an effort not to cause any morbidity, not to cause any long-term sequela. And then once we feel that additional surgery is not really beneficial, we could go to genetic testing. We could maybe discuss non-surgical treatment, maybe some kind of ablation for really small, localized lesions.
And that's kind of the perfect segue, although Dr. Russell wants to say something, and then we'll come back to the
Go ahead,
segue.
John.
Yeah, I think there was a great comment earlier about how there's a maximum dose of radioactive iodine that you can get. There's probably a maximum amount of all treatments that we can give, right? Whether that's radioactive iodine or surgery or pretty much anything. You get this limiting returns on everything that you do. And so one of the things that's really hard for patients to wrap their heads around if you've had a good treatment the first time around and maybe you suspect a recurrence, is that sometime your doctor may know that you have a small recurrence and they may elect not to recommend treatment right up front. And the reason for that is that with ultrasounds being as good as they are, and thyroid cancer most of the time growing as slowly as it does, there's an advantage to sometimes waiting to see what's going to happen. And I know I have one patient who, due to pregnancy the first time and then a wedding the next time and then a couple of other things, she kept kicking her surgery down the road, and it's become almost 10 years now that this patient has still not had surgery, and her disease that we know is a recurrence because we proved it on a biopsy it just hasn't grown. And for her, that's a fantastic thing. She hasn't had the big surgery that it's going to take to get there. And you know, I think that also alludes to the comment that was made about the quality of life burden that it takes on a patient, knowing that they're waiting for this cancer to come back. And I've got to have this surveillance all the time. One of the big things that we hopefully do as surgeons and doctors is we help to alleviate some of those concerns and say, hey, this thing may come back, but it's almost certainly going to grow super slowly. And we're going to help you through it. We're going to be here for you. And we don't think that this is going to kill you. And it's going to be something that you're going to live with. And we're here to help.
One might wager that what John says is not an outlier case, but maybe more the norm, right? It's not so much an extreme example of what most recurrences end up showing up as. Dario, do you want to move on to Q5?
Yeah, and we've got Jen Holcomb here to kind of help us through this question. Are there any less invasive procedures that might be available for a recurrence?
Yes, so we in the community have been fortunate to see a number of experts talking about ablating these smaller lymph node metastases with RFA. And I believe that now microwave ablation is also being used in some cases. What used to be done non-surgically primarily was ethanol injection, but according to recent conversations I've had with a number of physicians, that's no longer really considered the best course of action, just because that alcohol can leak out into the surrounding area and cause more scarring. And so these thermal ablation treatments can be a little bit more, well, I say a little bit, but actually quite a bit more precise in targeting these recurrences. And they can also help with reducing the risk of complications. And the statistic I have here for overseas data says that 70 to 90% of the lymph nodes treated with RFA disappear and don't come back. So obviously, Dr. Russell can probably talk better about this than I can because I am a patient advocate and not a physician. So Dr. Russell, would you please pick up where I have missed a few things?
I think you did pretty good, Jen. Not a lot to add to that. I think it's, again, this is a tool. And for a lot of patients, it's a fantastic tool because it's non-surgical, it's not as invasive, you're not using a number of, you're not having to do one of your surgery attempts that we already discussed has a finite number. Patients that may be more advantaged by a remote access or a less invasive procedure like radiofrequency ablation probably tend to be patients who have had multiple surgeries already or are a little bit older. For younger patients who may not have had surgery as many times, we worry about doing things that might make an eventual surgery more challenging. And ethanol, we know, made surgery more challenging. RFA in the lateral neck doesn't seem to be quite as bad. But again, all of these things are tools that can be fantastic as long as we know when to apply them.
And I forgot to mention one thing, so forgive my nerves. But we actually have done a few sessions on this in the previous ThyCa conferences the last 2 years, and those sessions can be found on the ThyCa YouTube channel, and you can watch sessions about may I be a candidate for a less invasive option, where we talk about primarily radiofrequency ablation. Also, I'm going to drop in the chat a link to a podcast episode that I recorded a year ago with 2 physicians who have done a number of these ablations of small lymph node metastases. And so, Daria, do I put that in the Q&A or where should I put that?
You can put it in the chat
Okay.
or the Q&A. Either way,
So Jen, thank you for that. And maybe John, in the last few minutes, you could tell us, as a pioneer in RFA in our field, you've said some things about what the indications are, age and number of recurrences already. Can you speak perhaps a little bit more generalizable, maybe some of the upper limits or lower limits of when you would consider RFA, like size, number, location, that would make a patient eligible for RFA in a recurrent setting?
Let's talk about the easy ones where there's not a lot of controversy about it, and then we'll work our way towards more controversial. So if you're a patient who's has a reason not to have surgery, then the question comes, do you need any treatment at all on this lymph node? Because again, there's some lymph nodes that don't need to be treated. And if the answer to that is yes, and you're not a good candidate for surgery because of other health problems or because of too many surgeries in the past, then RFA, or I would be a little hesitant with microwave just because it's a little hotter based on most of the international data. But thermal ablation in general can be advantageous in those situations, and that's not really controversial. Moving down the line, you start to say, well, what if you've got an isolated lymph node in a neck that has never had surgery? That kind of depends, because we know that about a third of the time, once it goes to the side of your neck, it's going to come back. And so the thought process of, will we be playing a game of whack-a-mole? And at what point is it good to try and shoot down that one lymph node? Or at what point should we instead wait until it's the right time to do a surgery? That's a very nuanced conversation. When it comes to multiple lymph nodes, I think most of us agree, and this is different from international data. There are some groups in China that say that less than 5 metastases, it's appropriate to use radiofrequency ablation. I don't know of any surgeons or treating doctors that I would really be happy to go to that would say that more than one metastasis in the lateral neck is an appropriate case for radiofrequency ablation. At that point, it kind of shows that you've got more than what you can see, and you probably should be treating that with surgery. Again, with the maybe possible exception if surgery has already happened in that same area in the past.
Great. All right, Daria, any last questions?
Yeah,
that you want to
so
mention?
hopefully we can squeeze in a couple more, especially since we started late due to my inability to find the start button. So one question, and I can kind of relate to this one myself, are labs ever false positive when they show like really low, like a 0.2 thyroglobulin? I've been there myself where that made me really nervous, and we retested and it disappeared. So like, how frequently does that happen where, you're testing that TG and it's like, it's almost undetectable, but it's not?
Anupam, could we ask you to answer something about an assay that I consider to be highly imperfect?
Yeah, I mean, this happens much more frequently than we know. There is one thought is there is a very tiny amount of thyroid tissue that's remaining, right? Especially in low-risk thyroid cancer surgeries. So that can stimulate. So that actually is not false positive, except it just stimulated a little bit. There are false positives. So we know biotin has caused interference with some of the thyroglobulin assays. Technically, it's more likely to be false negative if the antibody is high, but there are biotin issues. Sometimes there are like possible other antibodies, heterophile antibodies that could cause it to be false positive. So usually we just, if it's a very small change and the neck ultrasound does not show any concerning features, we just monitor that. We can also do it with a different assay. Technically, you can have it sent for a more specific, as opposed to a radioimmunoassay, have it done by the liquid chromatography mass spec. But in my practice, I found that just monitoring, repeating, making sure it's not continuing to trend up is very reasonable. But you can do the mass spec assay, which takes a couple of weeks to result.
Before we close tonight, I did want to remind everybody about the upcoming ThyCa conference that's happening in Houston. There would also be a virtual option available at that time. And it is September 20th to the 22nd. Registration is open if you just go to thyca.org/conference. And there was at least one person that put into the questions that they felt like they weren't alone, hearing that there are other people with multiple recurrences. And I wrote back and said, come to conference, because you'll meet all kinds of, you'll meet your tribe. So that's a fantastic forum. It's just a great conference. So please join us either in person or virtually. We do have one last question that just popped in about external beam radiation after extensive resection. And if they have BRAF plus TERT mutations, would you use external beam? We'll try to squeeze that one in and then we'll wrap her up.
Oh, she's trying to cause conflict, isn't she, Dr. Shindo?
Oh, that's from a doctor.
Yeah, it's from Dr.
Dr.
Shindo.
Shindo should next time be on camera.
Avi, do you want to take that one? This is highly controversial, but in some institutions, it's heavily used. So it's worth some discussion. Go ahead, Avi.
Yeah, it's a tough one. I think, as you said, it's really institution dependent, and if you have a dominant rad-onc service, then they like to give external beam radiation to patients with like locally aggressive disease, multiple recurrences. It's not really backed up with any solid evidence. I think as surgeons, sometimes when we really, and for the patients, it's something that happens very rarely, but when we operate on a very tough case and we feel that we didn't really do a great job because everything was stuck to the trachea, the esophagus, and then we feel that we need something in addition to the surgery. So in these cases, we consider we always bring it to the multidisciplinary tumor board meeting, and yeah, we can do that. I mean, to be honest, in my experience, I think in many patients that, I mean, we didn't give it to many patients, but in these patients that we did give external beam radiation, we've had long-term local control in most of them. But you have to keep in mind that external beam radiation has a lot of side effects, and it's something that we're familiar with in our head and neck, non-thyroid head and neck patients.
Perfect. It sounds like what you're saying is that the indications are there, but they're narrow. The consequences can be severe. Yeah. Great. Well, Daria, I think all good things must come to an end. I wanted to thank Dr. Russell, Ms. Rachi, Schindler, Cotwall, and Ms. Holcomb for doing a fantastic job. These are leaders in their respective fields, and it's great that we got them all together in a panel. Daria, anything else to add before we wrap up for tonight?
Just a reminder about upcoming events. We do have another session similar to this on September 12th, and then another one on December the 12th. So, and by then we'll be much better at using Zoom events. So.
You did a great job, Daria. Don't worry. It's a new
Yeah,
technology.
but the hiccup in the beginning was not fun. Thank
Great.
you, everybody, so much for your kind attention to our audience. And I've been in their shoes, so I know how much we appreciate when doctors are willing to share their time with us and answer our questions. So thank you.
Thank you, everybody. We'll see you next time. All right.
Take care.
Thanks for the invitation.
Thank you.
Thank you.
Good night.
Bye, everyone.
Good night.